So hello everybody. It gives me a distinct pleasure to welcome all of you for the sixth session of epilepsy surgery case by case, step by step. And as you know, this series of webinars have been developed by the leadership of International League Against Epilepsy, Asiano-Oceanic region, for the purpose of closing the knowledge gap for epilepsy surgery. And because most of the people felt that the knowledge dissipation could be optimal if it was based on a case study. So that's the reason we took it up on basis of cases, starting with the most straightforward cases and going to more complex cases, and having an unhurried discussion and also presentation and interaction with the faculty for at least an hour, followed by a didactic lectures for faculty in order to close the loop for knowledge. That would close the circle for us to have knowledge in that particular area. And that's the objective for us to start this webinar. And on behalf of the International League Against Epilepsy, let me share my slides. I would like to thank the leadership, Professor John Dunn, who has not been able to join us today, Professor Ikio Ikeda, who was a past chair of AOILE, and under the leadership of both of them, we were able to really go ahead with this series of webinars. And I would also like to thank my co-convener, Professor Kensuke Kawai, without whose help, I don't think anything of this would have been possible. And today we have an exciting program lined up. So we have a case presentation on temporal plus by Manjari. And then this would be followed by interaction with the audience as well as with the faculty. This would be approximately for 45 minutes to 50 minutes. And then there would be two lectures, one by Dr. Nandini Mulatif, who is the chief epileptologist from King's College London, on a brief lecture on identification of red flags for mesial temporal epilepsy. And this would be followed by a very nice lecture by Dr. Bertrand Divoux from Paris, who would be speaking on surgical management of temporal plus epilepsies. And this would be followed by question and answers. So for those of you who have missed these lectures, all of them are there on the website. And as you can see, this is the sixth of the series. So we had on right temporal, left mesial temporal sclerosis. And then we had one on cortical dysplasia with Australian group. And then we had on lesional temporal lobe epilepsies. So we are progressing step by step. And this time we will be having a discussion on temporal plus epilepsy. So before I proceed, a word of thanks and acknowledgement to IPCA, who have provided this webinars through an unrestricted educational grant. So with this, I will request my co-chair, who is the professor and chair of Jitsi Medical University and vice director of Jitsi Medical University from Japan. He is also the president of Japanese Epilepsy Society. And with me is the epilepsy co-chair for the AOILE to please moderate the rest of the session. So Professor Kawai, you can take over now.
Okay, now we'll start today's webinar. So this is a sixth session, and focusing on the red flag of temporal lobe epilepsy and temporal lobe epilepsy plus. And maybe before we start, Sarat, please show the
yes.
CV of faculties.
Yes.
Yes, Dr. Devoux, Bertrand Devoux. You can see his CV here. His current position is a consultant neurosurgeon, Department of Neurosurgery, Variboise Hospital, Paris, France. And he's a professor of neurosurgery, University of Paris, Descartes Faculty of Medicine. And his current areas of research is development of alternative techniques for intractable epilepsy in eloquent areas, and development of intraoperative optical imaging, full field and dynamic optical coherence tomography, two-photon fluorescence imaging. And move on to the Dr. Nandini Mulati. Could you? Oh, yes. So she's a neurophysiologist and epileptologist at King's College Hospital, London, and she has pioneered the use of SEEG in epilepsy surgery program in the United Kingdom. So she also launched the United Kingdom Epilepsy Surgery Networks, which she founded in 2009. So they we are very glad to have these two very famous and well-known epileptologists and neurosurgeons here. And now, as always, we start with the Dr. Manjari Tripachi's the case presentation. So,
Okay, sorry,
Dr.
sorry.
Manjari Tripachi is a professor of neurology, All Indian Institute of Medical Sciences, New Delhi, in charge Center of Excellence for Epilepsy and MAG Resource Facility. And she has a amazing number, a lot of research publication, including the New England Journal of Medicine, and a lot of very high highly evaluated the valuable papers in the field of epilepsy. Okay, now Manjari, could you start the case presentation?
Thank you. Thank you to this forum for having me present this case. I will just be going through the case, and then I will in interim be asking the opinion of the panel, esteemed panel, Dr. Ikita, Dr. Kensuke, Dr. Nandini, and the others here. So here we have a young boy who came to us in around 2016. And at that point of time, he was of 10 going to 11. And the history given by his parents were that since the age of 8 years, he'd been having episodes. So total duration was around 2.5 to 3 years. And initially, these episodes were a bit prolonged and unpredictable. And he would, however, perceive that the episode is coming on, and they would invariably kind of generalize. But then he was started on medication, and since his medication was altered and sometimes optimized and changed, the frequency of these episodes did reduce from several a day to 5 to 15 episodes in a month. The duration of the episodes before he came to us was briefer. It was just for about 40 seconds, as per what they said. They were very brief episodes. The parents had not noted any particular time of the day or sleep which brought on the seizures, nor had they noted any obvious provoking factors like bright lights or stress or anything like that. So if we went on to ask them whether there was a single episode type or there were different episodes, they did tell us that the initial episodes were a little different compared to the ones currently. The current ones were mostly consisting of some eye blinking, and then there would be a lack of awareness or loss of awareness, and he would not respond and maybe give a stare. They were not particular about any particular side. And then he would have fidgety movements of his hands. He would often pull at his trousers or his clothes. And for them, they had thought it was more of the right hand than of the left. But there were definitely these fidgety movements which were going on. But the episodes in the past, where in the beginning of his epilepsy, consisted of his eyes and head and body turning to the right. And they were quite consistent with this, that he would turn to the right, the eyes and the head, and sometimes even the body. And the little boy did tell us that he used to in fact see a written word called gold, which is in Hindi, it's called swaran. So he would see Swarna written on some part of his visual field, which he could not describe whether it was right or left. And he would just say कि बाहर में दिखता था. So it was like on the outer. But he was not very sure whether it was on one particular half and on the other. He had never experimented with closing his eyes because he was quite flummoxed by this appearance of this word in his visual field. On further probing, he said he would see dolls also. And these dolls had very prominent eyes and nothing. He was not able to see a color on the dolls, but they were definitely doll-like figures, which he would see. So these were, this is what was happening in the previous episodes. So these episodes where he would see this phenomenon and turn to the right had actually stopped for about a year before coming to us. So this was his history. Now, based on this history, definitely the hypothesis was that he seemed to have focal seizures and they were involving previously certain visual phenomenon in the form of formed visual hallucination, in the form of seeing a written word and dolls. And then there was a turn to the right with the head and eyes going to the right. So the lateralization seemed to be the left, and it seemed to be the left. Obviously, it would not be the primary visual area which is giving rise to all of this. It has to be the visual association cortices or regions nearby the posterior temporo-occipital junction which were causing this. But then these episodes had completely stopped, and the episodes which the parents were describing now just consisted of loss of touch with surroundings with some eye blinking and some automatisms. So we could stretch the eye blinking to be of posterior origin, because eye blinking is very often, if it's bilateral, which is what they described, it wasn't a unilateral eye blinking. So eye blinking is usually, again, occipital, temporo-occipital in origin. So again, the hypothesis was that it was definitely something around that area on the dominant hemisphere. So with this in mind, the patient did walk in with an MRI to us, and the MRI was read in our neuroradiology conference, which I'll be shortly showing you. There was no significant history of birth hypoxia or hypoglycemia or any problems during his delivery. It was a normal delivery. His development was normal. He's pretty much normal going to school. And there was no significant family history. He was on multiple drugs, as you can see here. He was on 4 anti-seizure drugs prior to entering our monitoring unit. And all of them were on good doses. And he still was not responding adequately. On examination, he was a pretty cooperative child and he would answer almost everything, whatever was asked of him. His visual fields were normal, both on bedside evaluation as well as on a visual field charting. The neuropsychologist did evaluate him and found there was impacted verbal memory with a normal visual memory, and the intelligence was average. So he came in with this MRI to us, and we will just see it. Is the MRI visible?
Yes, okay.
Yes.
Yeah. So as you can see here, this is axial 3D flare, and these were the snapshots, and it shows flattening and atrophy of the left hippocampus with hyperintensity. However, the radiologist felt that the hyperintensities were similar in the right and the left temporal, but the volume of the left hippocampus definitely was smaller. Again, 3D coronal flare, which shows a similar hyperintensities. And if you go on, we see the left hippocampus now. So there was a flattening of the left hippocampus, though the signal seemed to be similar in both the hippocampi. And the radiologists were of the opinion that there is a left temporal sclerosis. So though there was a red flag in the semiology, with this he entered the epilepsy monitoring unit with the hypothesis of left temporal, which was less than the possibility of having a temporo-occipital or posterior lesion in the visual association cortices. And his semiology is seen here. So almost all his episodes were similar, and I'd like the opinion of Dr. Nandini on what we saw. I can play it again if need be. Dr. Nandini? Yeah. So here.
You're muted, Dr. Nandini.
Sorry, I hope that's better now. Thank you very much. A very interesting case, Manjari. And right away, our attention is drawn to a number of very interesting features in this case. So I just have a few questions at the outset, if that's okay. I mean, he's an 8-year-old boy, and I appreciate he's a young lad, but you may still be able to get some history. Was he able to give you a history of, for example, epigastric rising sensation, anything apart from this visual aura?
So we did ask him about any discomfort or gas rising, which they commonly call in India. Now, probably he was not able to understand what we asked him because he never told us about this in the history. All in the history we got was a visual aura. So when we saw these episodes which were having this, he would just keep waving his hand upwards as if to say he's going to puke. We went back and asked him, and the mom he said, yes, this does happen in the episodes, but not all the episodes. Some of the episodes, maybe, 50% chance of it happening or not. And then they did tell us, yes, that, looking at the video EG, yes, there was some of these episodes which are associated with this discomfort and nauseous sensation.
And was there any, for example, funny smells, funny tastes in the mouth, or fear, anything else at all apart from visual?
There was never any metallic taste or any unpleasant taste or any smell or those kind of other phenomena. So not all these episodes had this epigastric rising and nauseous sensation, which he so clearly demonstrated here. There were only few of them which, according to them, was 50% chance of coming. And this was not told to us in history, but actually when we saw the events and went back to them, then they said, yes, they were there in 50% of the episodes.
Thank you for that. And then you did say that there was no antecedent history. So there is no history of febrile convulsions at all?
No, not at all.
Okay. So then coming to the case itself, as when you take the history, the visual symptomatology is so much in the forefront, especially being able to see formed visual hallucinations, letters of, saying gold and pictures of dolls. So as you correctly said, that immediately takes you posteriorly into the association areas, visual association areas. As far as the seizure itself was concerned, there were a few things which are, on observation, because there is a subjective phenomenology, but observation, the child was not doing a lot. So it is a hypomotor seizure. He was lying down, and then you start seeing him, chew and pick. It was a very long seizure. If you showed us this, everything you showed us was the seizure, it's a very long seizure. Usually prolonged seizures, again, point to a posterior onset. And what I couldn't understand is whether he was dysphasic or it seemed to me from the video that he was in fact continuing to speak during the seizure.
Yeah, but he was not answering relevantly. Like when the nurse asked his name, he mumbled something out, but he was unable to tell his name, his actual name.
So you think that there were no formed words. So he was probably dysphasic.
Yeah.
I see. Okay. So
yeah. So now if you go back to the video, Nandini, and you see the initial part, we also thought these oral automatisms and these picking movements of the right hand are, coming in first. But if you look carefully,
I couldn't see very clearly his eyes. I thought there was some eye deviation, and I wasn't.
So if you look carefully, he has a blinking of eyes, which comes in first. So we can go back and look at it again.
Yes, please. Yes, thank you. So on the EEG, please tell us.
So the blinking of the eyes has kind of started.
Yeah,
much before
and the eyes deviated to the left.
Yeah, much before the eyes have kind of gone to the left, and he's blinking his eyes. And then he starts some fidgety movements with his hand, and then he starts with the oral automatisms.
And at what point does the EEG change, scalp EEG change
start?
So
we'll just see that. So, with the onset of this blinking of eyes as the first thing, and the eyes going to the left, if you look at, as you analyzed, Nandini, was that it was a pretty prolonged seizure. It was a pretty bland seizure. And there were these nauseous vomiting and signaling movements, though he was not able to speak, so he was aphasic. So when you look at the semiology, we thought, we were also misled to thinking that, it's a bland seizure, it's a prolonged seizure, so likely to be temporal. And then there's this nausea coming in, so, it's described more in the non-dominant temporal, but then he was unable to speak and answer, so that would go for dominant. And we already had an MRI read, which was suggestive of bilateral, temporal left more than right. So we were also kind of puzzled. But the eye going
there are
to the
a lot
left,
of red flags.
There were a lot of red flags. Yeah, the eye blinking and the eyes going to the left as an initial feature was a kind of red flag. So we went to look at the interictal EEG, and you can see here this is the interictal sleep EEG, and very clearly, of course, they're slowing because he's in sleep, and you see the sharps and spikes, and they seem to be pretty much. Yes.
May I interrupt? Maybe Dr. Ikeda, do you want to add anything on the semiology, just to have a varied point of view?
Yeah, thank you very much. I totally agree with Nandini. So the most important things that the patient used to have so-called, not the elementary visual aura, but the complicated visual aura, like was or the dolls are seeing, which strongly suggest, as the Manjari mentioned, that this is actually occurring from visual association cortex, or just the bridging area between the major temporal and also primary visual area, like posterior major temporal areas. So that's I totally agree. And then it's used to be, but it's now disappear, and then currently patients have more or less that some the temporal lobe complex partial seizure with the oral alimentary automatism and hand automatism without any big lateralizing sign, except for that initial head starting to that the right or left. The laterality is not so clear with the later parts of the automatism, but thinking these kind of things, I personally feel that the patient used to have a primary seizure focused presumably at the posterior parts of the major temporal, or posterior to that the end of the posterior hippocampus, and then it's the bombardment to that the anterior hippocampus, which may develop that the dual pathology, resulting in that the atrophy of the anterior parts of hippocampus. And then the initial original visual aura as a complicated visual aura may disappear because the patient may lose his consciousness while it's usually developed the visual aura. That's what I understand, because we, in the past or in the previous literature, the ones we implanted the subdural electrode, that's the major temporal occipital area, which could make this kind of complicated visual aura. So that's quite similar to our previous cases arising from that the posterior part of major temporal area. That's what I just make comments.
Yeah, I think that's perfect, Dr. Ikeda. It was a wonderful analysis, and yeah. So
and
can
looking
we?
at the EEG, sorry,
Yeah,
Manjari,
yeah,
to come, and
yeah.
the history is all, as you say, pointing towards the posterior part, as Professor Ikeda said, of the either posterior temporal or temporal-occipital region associated. But the EEG is again a second red flag here, because the interictal abnormalities are clearly in the posterior quadrant and not in the anterior temporal region that you want to see. So data is mounting up.
Dr. Ikeda, your take on this interictal sleep epoch?
Yes, when we look at this, the EEG, it's a quite large sharp waves, presumably the negative phase reversal at the T5, and then that is also somewhere at the T5, mostly the maximum area, so which may spill out from the basal posterior temporal area. That could be one possibility, but if it is so, it is too large. But I think anyway, that's since it's not the reverse sharp waves, definitely located at the lower posterior temporal area of the left hemisphere. So some primary interictal focus may be located at the inferior parts of the posterior temporal, which may connect to that the much more medial left posterior temporal area. Otherwise, we can't see anything at anywhere from the anterior temporal area. But that is quite striking, with some polyspike-like activity at the same times, and also it may extend it to that the O1 as well. Yeah.
So though the semiology was prolonged and bland with automatisms and hand automatisms, there were red flags, obviously, of the visual aura and his eyes going to the left and eye blinking. And rightly so, the experts have flagged these red flags. And now we go on to the epoch just before the ictal onset. And you can see here, he's blinking his eyes and sitting And here are the ictal onsets. As you can see here, there is a sharp and spike, which is seen at T5:01, and then it evolves into a fast kind of rhythm, and then it slows down to a theta rhythm, and kind of spills over to the right later, again posteriorly. So, any comments on this, Dr. Nandini and Dr. Ikeda?
Go ahead. Go ahead. I had
Thank
that.
you.
Yeah.
Yeah. I think actually the prolonged seizure, a very prolonged seizure like this one, which was, I think, was it a couple of minutes at least?
Yeah, it was minutes. Yeah.
I put it to my mind posteriorly behind the typical mesial temporal sclerosis.
Okay.
And the onset, the interictal, so far, what the semiology, the history, the interictal EEG and the ictal EEG are all concordantly pointing to something in the left posterior quadrant. I think Professor Ikeda makes a nice point that typically basal temporal onsets or sources don't show much of a scalp EEG change because of the fact that it's deep. So whatever we are seeing is only after it spreads, or it may be on closer to the lateral surface posteriorly, but
yeah,
slightly, definitely behind the mesial temporal sclerosis. So this is the question: do we have dual pathology here or not?
Okay.
We're very suspicious. There's certainly something more than the mesial temporal sclerosis. This is not straightforward mesial temporal epilepsy.
So then it further evolves like this, and you can see the spikes which appear more prominently, and then again the slowing, and it goes on like that. So now we go on to the MRI, and I'll just play the MRI, and you can ask me to hold, you can ask me to replay it. So this is the HLT1. So we now go to the coronal. So go to the axial flare. We can see it all over again, maybe. T2 coronal oblique. So this is arterial spin labeling. So shall I go on with the PET MRI fusion, or would you like to see any particular sequence again? And could we make out anything on what we saw? Dr. Nandini, Dr. Ikeda, Dr. Kensuke, and the others on the panel.
Yeah, may I ask?
Dr. Devu.
Yeah, they were.
May I ask to take a look of the MRI, which for the first time show at the beginning of this presentation, which strikingly shows the left hippocampal atrophies at the axia image. Yes. Yeah, that's a little bit difficult, but do you have the, all right. Initially, I feel that the left lower slides, and the left the occipital, left medial occipital to posterior temporal area may be a little bit thick and high intensity, but that's a little bit subtle. But I don't know yet over there. But you could move a little bit.
So Manjari, you could run the axial sections.
Okay, I'll run the axial
flare sequence.
Yeah, I'll run
axial flare sequence.
Axial flare, here it is.
And slide it with your slider rather than running it. Yes. And Dr. Ikeda could ask us to stop wherever he wishes to stop.
Yeah, could you stop over there? When I compare right and left.
Sorry.
Yeah, that's fine. When you compare right and left, the boundary between white matter and then the gray matter on the right side is much clearer than the left side. That's what I would like to just only mention about the slight changes that the left, the posterior major temporal to occipital area. Otherwise, I can't say anything at this moment. Thank you.
So the gray-white matter differentiation in the left basimesial temporo-occipital region is a little blurred.
Yeah, that's what I slightly feel, but I could not strongly convince myself anyway.
Anything else?
Prof. Devu, did you have a comment?
Well, no, I agree with the comments of Dr. Ikeda. We obviously are looking for very slight abnormalities in the basal and posterior temporal area. Anteriorly, we can just observe that not only the hippocampus is atrophic, but also the amygdala and subiculum. I mean, the global temporal mesial and basal atrophy with a slight difference between the right and left temporal lobes. But it's posteriorly that we have to look at something. Maybe we could also relook the coronal flare and slowly looking at the base of the ventricle. We might see a tiny area of hyperintensity on this side.
So go to the level of occipital horn, Manjari.
Yes, yeah. Well, posterior temporal part of the ventricle, and then.
So I'll start going from here.
Yeah, a little bit more posterior. Yeah, once again. Yeah, a little further. Stop. Right, stop here. No, well, difficult to say. Yes, stop. No, more posteriorly. No, a little more anteriorly. Yeah, I think we're too posterior now. Yeah. There's some asymmetry of the temple, basal part of the just lying underneath the ventricle, but I don't know if it's significant or not.
So the white matter and the gray matter on the left, you could say around the collateral sulcus, between the fusiform and the
and lingual gyrus,
lingual gyrus. So this particular area looks a bit bulkier and kind of not as clear and clean as the other side, maybe. Yeah.
For sure, according to semiology and the EEG abnormality, that the area that where we have to look for something.
Okay, so we did think that.
Well, we thought it's completely normal.
Yeah, I don't think there's anything convincing. You know, we are looking hard, but this is where the PET MRI really comes into its own. Co-registration would be really helpful.
Yeah.
And again, sliding would be really helpful, Manjari, if you don't mind.
Okay. I'll go do it slow.
So this, if you go back again, go down one slide, there's certainly asymmetry. Now the left in your is on the right side of the slide, right? Or which is left, which is right?
This is the left. This
we can't see your mouse. So
okay, because I have put my hand on the mouse because otherwise it'll move. Yeah. So I don't know how to show you my left, but the left
is on the right side of the slide.
The left is on the right. The left is on the right.
Yeah. So you can see some asymmetry at this cut and even lower down.
Okay.
In the lateral temporal hypometabolism, well, posterolateral, not here, just one up.
Could you see my mouse?
No, it won't show your mouse. That's a problem with sliding it. I can't move my hand.
There, at this slide, you see, you can see at this cut, you can see an asymmetry between the two sides.
So you find that the collateral sulcus is extending much more anteriorly onto the right.
Collateral. It's on the lateral surface.
It's on the lateral surface.
Okay, you're saying the lateral surface. Okay.
Yeah.
Okay. Yeah, you see a larger blue blob on the lateral surface on the left.
Or there is less orange.
Yes.
There's an interruption of orange.
And yes.
There. I guess none of us can show.
I think you can remove the mouse. It won't slide.
Okay.
Yes.
This one, you say this one?
No,
Lateral, yes.
there. Yeah.
Okay. So
I say at the same time, the medial temporal posterior part is also.
Yeah, you're
Yeah,
absolutely right, actually. If you compare the two, it's also asymmetric mesially. You're absolutely right.
Yeah. So.
And that's certainly, it's not mesial temporal, it's mesial temporoccipital, isn't it? That's right. So certainly it's part of the epileptogenic network. We weren't
So here,
100%
if you see
sure.
this, you see this whole area.
Yeah. Again, that's hypometabolic. That's clearly asymmetric, isn't it?
So more of mesial. We thought of more of mesial, but
it is, of course, you were right to point out it is mesial and lateral, but it's also mesial, definitely.
So that was on.
That was positive for us.
Yeah. So then we go ahead. You want to see the axial pector? So we just saw that, no?
Yeah.
Okay.
Go to the axial coronal.
Okay. I'll halt it when it reaches the temporal.
So the entire temporal lobe is hypometabolic. I think that's very clear. You can stop it here.
Keep going back.
So
you see that asymmetric continues mesially.
this one?
Yeah.
Yeah. Compared to that, it's definitely mesial.
And if you keep going, just so we see the extent of it, please.
You still see it here?
Yeah. That's probably stopping about there, isn't it?
Yeah. So occipitals were clean. Sagittal, anyone wants to see that? So really can't make out too much.
I think, it's difficult to appreciate it at that speed as well.
So this was the MEG of the patient, Nakul. You can see here in the MEG, the left is the left and the right is the right. And we see this kind of polarity here, which is exactly showing the dipole in the posterior mesial left occipital, as we had suspected in the PET MRI fusion. The MEG was done much before the PET was done or the fusion was done. So we had the MEG with us before. Did show the spike propagation from that posteriorly, in fact. It showed the green is the end of the spike propagation. So it showed it going posteriorly for that particular dipole which we had sampled. Now, this is just the PET CT. It's not the PET MRI, but we have it with us. And you can see here that as we go a little more inner, we see this. This is the right and this is the left. We see this, something over here and here, but we're not very certain, but yes, it's there. This was the ictal spect, the syscos. We don't have the syscom. The syscos showed us something in and around that area. So in the spect, syscos and the PET, the right is the left, as we see in MRI. So we're done with the MRI. Done with this. I don't know why it went back. So since we were dealing with the dominant hemisphere, and definitely we thought that there is a flattening of the left hippocampus with the signal change, and the semiology is suggestive of a posterior temporo-occipital with a drift of the eyes to the left, which we could explain by the ipsilateral drift, which is seen in the parietal region. And we had the video EEG, which was suggestive of the left posterior temporo-occipital. We had the PET and the Syscos and the MEG, all pointing towards the mesial left temporo-occipital. We did a functional MRI for word generation, which is for the Broca's area, which actually showed a bilateral representation. The comprehension was still there on the left, but also shifted to the right. The semantic memory showed a major representation on the left as compared to the right. And his visual functional MRI showed the visual representation posteriorly towards our purported, area which we were interested in, which was here. So we did go ahead with, because we were still not convinced about the structural aspect of it. We were very much convinced by the PET.
So before you proceed, so I'd like to take opinion of Dr. Divu and Dr. Kawai on what they would do now with this information. So we have got the patient investigated with every possible investigation, and we have come out with an hypothesis. Definitely there is a mesial temporal sclerosis, but the PET MRI shows hypometabolism much more posterior on the inferior side as well as the lateral side, but the MEG was correlating to the medial side more than the lateral side. And the ASL again was more or less correlating with the PET. And the Syscos again showed a very bright area on the lateral side. So with this fund of information, would like to ask both of you and also the other experts on the panel on how you would like to proceed.
Dr. Dawood, you go first.
Yes, well, thank you for this interesting case. Definitely, there's not only a mesial temporal lobe epilepsy, so I think that mesial structure removal wouldn't be sufficient. What we have to discuss is, do we just consider as we have enough to go on and proceed to surgery, which is a surgery in the dominant lobe, extending pretty far posteriorly and involving, I think, basically the region of both banks of the collateral sulcus. We would probably do, as an addition, a functional MR of a reading to look at the activation area for lecture, for reading. You have language tasks, comprehension, and you didn't. Maybe you did it with a reading task.
So the word generation task paradigm. There's a screen in front of the patient in the MRI which flashes single words, then double words, and then a sentence. So he's reading single and then double and then a sentence. So the word generation task paradigm has that inbuilt in.
Okay, and so what you show is this word generation does not create any activation of the occipital temporal.
Yeah, so in this particular, we could get the information in this particular analysis because we are focusing on the Broca's area. He probably has filtered that out, so we can get that information with the data which is there. Yeah, it didn't strike me. I would have got it done. Yeah, you don't have.
Sorry, I forgot to disturb you. And then, do we have enough for just to design surgical resection planning, or we need to learn more on the interaction between the posterior and probably the original focus of the seizure. Is basically more, it looks more than temporal occipital junction seizure onset, spreading anteriorly to the mesial structures of the temporal lobe. Or do we proceed with depth implantation electrodes to make sure that everything looks like did the right hypothesis, and then proceed to surgery? Well, to that point, I'm not completely sure of that. We go straight forward to surgery or not? Probably in this case, we would probably propose depth implantation, on both occipital and temporal lobes, and to confirm this that we'll have just to remove the collateral sulcus area, sparing the reading area, and also legal structure as well, because definitely hippocampus and parahippocampus gyrus is certainly abnormal. I don't know what's the opinion of my other colleagues.
Professor Devu, did I understand correctly? You were suggesting bilateral implantation?
No. It's
unilateral, right?
Left side. It's left side epilepsy, and we have a hypothesis of, but at that point, I'm not sure of what we have to remove or to leave in place. This, and so I would certainly do just a unilateral exploration.
Is sampling the lateral and medial surfaces is what
basal, mesial, and basal lateral structures. At the occipital junction, occipital lobe, and a couple of anterior temporal electrodes, but for sure they would be involved in the seizure onset.
Dr. Kawai, you want to add anything to this?
Yeah, and before that, can you show me again the verbal memory function MRI?
Oh, we just did the semantic memory, which is
semantic,
semantic. This is the
and this coronal section, which side is which?
It's this coronal one.
Yeah.
The coronal one, the left is left and the right is right.
Left is like, so the left, the sclerotic hippocampus is activated, you mean?
Yeah, it does show certain activations, yes. Very minimal on the right, but it's maximum on the left.
And in your first slide, in your presentation, you mentioned about he had the verbal memory impact. What do you mean verbal memory impact?
So he had an impaired verbal retention to paired words and other verbal memory paradigms. So he had an impaired verbal memory retention. His verbal memory was down.
So his verbal memory is already down.
Yeah, on the psychological testing, yes.
I see. So anyway, so we have to resect that posterior temporal basal temporal area, fusiform area. And the problem is, the important issue is whether we resect the hippocampus, anterior hippocampus or not. And because although it is activated by a semantic memory task, but his memory, the performance is already kind of impaired. At this point, I may add the resection of hippocampus to stop seizures. But as you already shown, if you proceed to SEEG, then you will see how the anterior hippocampus is involved in seizure development. Then I want to see that too. And another comment: in the early disease stage, he had the visual hallucination of both doll and letter. You see, both
both would not occur at the same time. The more frequent one was seeing a word, but occasionally he would see dolls, and he was not able to describe the dolls as well as he would describe the word. Both of them never occurred together.
Not together, but anyway, so both doll and letter. And you mean fusiform jealous is a kind of face, basal face area, and if you do the map the face and also letters, those base posterior, the fusiform area is a kind of mapped area of both face and the letter. So that shows the fusiform area is also originally pathologic, I guess. Yeah.
So that's what we thought, the fusiform was involved because of these kind of hallucinations.
That's really excellent analysis, Dr. Kawai. So we'll just show you what we have done and what was our hypothesis.
Do we have time, Dr. Sharath? Yeah, should I?
The case is interesting, obviously.
Has gone by. Okay, so he had a similar seizure in the...
Manjari, can I just tell a few words before you show? Yeah. So now the background is our center, it's a government-aided center, and even though we have every kind of investigation available, and we can do it completely free of cost if the patient cannot afford. But the SEG electrode is something like the out-of-pocket expenditure. So we do have a big challenge, So the way we try to work out is we try to maximize the non-invasive investigation, form a strong hypothesis, and then try to go with as minimal SEG as possible, and then use electrocorticography to tailor the final resection. So we do a combination of SEG with electrocorticography. So in this case, as a surgeon, I wanted to know only two things. A, whether the hippocampus is active or not. B, is there anything coming more posterior to the hippocampus? Because I knew that the area of resection would be both lateral as well as medial on the inferior surface. And now our radiologists, they felt very strongly that even the right side, there were signal changes. So they were saying perhaps it's some kind of an early mesial temporal sclerosis on the right side as well. So with this, I know the standard exploration would be not less than 7 to 10 electrodes, but we just put 3 electrodes, one on the right side, one on the left hippocampus, and one having about 18 contact electrodes starting from the lateral portion where the SPECT was active, going right up to the area where the PET was active medially along with the MEG area. So Manjari, you could show the SCG readings now.
Yeah. So he had a similar seizure. So I won't go and show the seizure. In this seizure, he also had a nose wipe with the left hand at the end. So this is the left lingular fusiform junction. Actually, it's in the fusiform. And we can see here, these are the ictal onsets to the contacts 13, 14, 15, 16. And again, this is how it proceeds. It does involve the left hippocampus later, and then proceeds further and evolves further. It has involved the left hippocampus and left amygdala.
On stimulation. Sorry, the onset is clearly much preceding.
Yeah. So you can see we have annotated what is happening. So here his eyes actually go to the left at the onset, and pretty much nothing happens. And as towards the end, you can see the annotation where he's having automatisms with the left hand. So the automatisms come in much later. So the eyes again go to the left towards the end of the seizure. On stimulation, the reds are where we could reproduce the seizures, typical seizures on stimulation.
Did you get his visual hallucination?
Yeah, so he did see, he didn't see a golden written word, but he did see some kind of formed, figures, not exactly dolls. So we did get a visual hallucination, and we did get the eye deviation. These were the two things which we mainly got. we went back and looked at the MRI after this, and we thought maybe this is the area. As you can see, the white matter very well here, but here it is kind of blurred, and basically the posterior fusiform here somewhere.
Basically, we thought it's a collateral sulcus, which is the junction of the lingual and the fusiform gyrus.
Yeah, this one. So around this area was the stimulation producing seizures, and with this in mind and knowing fully well that there is a rich network from this area both to the temporal as well as also the inferior orbitofrontal going to the occipital, though of course we don't expect this to be active in this seizure. The probability that was there in the beginning, and then it kind of kindled the inferior occipito-temporal fasciculus, kindled a kind of hippocampal sclerosis because his left hippocampus was definitely atrophied, and also did produce semiology which was temporal in the latter part of the seizure. So that was our hypothesis, and with this.
So I will show a short video of the surgery, and then we can. So I would like to acknowledge my colleague, Dr. Ramesh, was also for the surgery. So initially we did an electrocorticography on the surface, and then we did neuronavigation, and I did a lateral resection of the area which was positive on MEG. Which was positive on PET as well as on SPECT, which was highly epileptogenic. And then we did electrocorticography again. There was a marginal improvement to grade 2. Now at this point, I was undecided whether I should remove the hippocampus or not. So the points in favor of removing was presence of a structural abnormalities, which was clearly a mesial temporal sclerosis. So it has gone to the level of irreversible kindling, stage 3 kindling, which means it's autonomous. So if I remove just the posterior part, the hippocampus would sometimes flare up. That was a point in favor. But the point against was that the SCG did not show any spikes from hippocampus. So that's a surgery showing disconnection of the posterior part of the hippocampus. Then we do medial disconnection and lateral disconnection of hippocampus, then anterior disconnection. And then finally, I decided to remove the hippocampus, and we removed the hippocampus in toto. So, and then following the removal, we went right up to the tail, where it was turning around at the level of superior colliculus, and disconnected the hippocampus at this level, so that the temporal efferents are completely disconnected. And we also removed the ventral amygdala in order to have a closure of circuits. So basically we had 2 openings. So after this, the ECOG had become grade 1. So we had 2 openings. One posteriorly, we removed that area. We left a chunk of intermediate normal tissue of normal brain, and then anteriorly we did the resection of anterior temporal pole as well as amygdala and hippocampus. So with this, the biopsy was that of a cortical dysplasia along with mesial temporal sclerosis. He was seizure free. But the question obviously is that people may criticize that was it really necessary to remove hippocampus if the hippocampal recordings were normal? And secondly, would we have benefited with more number of SEG implantations? Or is it okay just to do with such minimal number of electrodes of just 3 electrodes? So maybe we can have short comments because we are already running short of time, and then go for the next session.
So was there any visual field defect, Sharath?
Yes, the patient did have an inferior quadrantopia, and this was explained to them. So we went with, because that is inevitable, because the area where we were removing, those are the areas where the visual fields loop around. So this was inevitable. So, I mean, that was a primary epileptogenic networks, and we had to tackle that.
Sure. Just checking.
Sorry.
But I think that you did the right thing in taking out the hippocampus, because seizure, I mean, this is a case of dual pathology, and the outcome in dual pathology is best if you can resect both the hippocampal sclerosis and the dysplasia, which you have done. The question, which I think where money is not an issue, is whether I think many people would have used more electrodes posteriorly to tailor the resection. You haven't told us what is the seizure outcome?
It's class 1. He was completely seizure-free.
That's excellent. So you've got a good, I mean, in fact, you've done very well with the 3 electrodes, you know.
In fact, his father just wrote 2 weeks back. He's planning to, vaccinate him. The child is grown up. So the vaccines for the teenagers just started, and we said, go ahead. So
Of course.
he's received his
So-
Covaxin.
No, that's really good. So, I mean,
Sorry.
tailoring the resection would not have made that much of a difference, you know, but I'm sure the surgeons will comment on this better than me.
Sorry, from a neurosurgical point, let me make one question. So, do you think about transcentorial supracerebral approach? So you can first approach to the fusiform gyrus, and then evaluating hippocampus, and go forward. That is another option. I think
that is an excellent suggestion, Dr. Kawai. And that is what, if today, that is what I would have done in order to preserve the visual. But this was, I had operated this almost, I think, 2006. So it's about.
I see. Okay, so the.
Can I ask one question? Yeah.
Sure.
This is the left, the dominant hemisphere, and also the resection of the fusiform may be going to that at least the posterior to middle, where I don't know how much that the anterior part was resected. But the left fusiform gyrus is that the important for semantic functions. So I just wondering that after surgery, the patient may lose that the semantic function or not, in addition to some other the memory. That is my questions.
So on the FMR, Manjari, yes, Manjari, you can answer.
You can finish. I'll take over then. Yeah.
So on the fMRI, the semantic memory was bilateral, even though it was slightly more on the left side. So we thought we will like to take that chance, because if it was unilaterally represented, then maybe our strategies would have been different.
Thank you very much.
So in the preoperative counseling, which almost takes us an hour, we had spoken to the patient's parents and clearly told them that we are dealing with eloquent dominant sided lesion, which is not just single, which is probably more situated in 2 areas, and definitely removal of one may not make him seizure free. And we also explained to them that memory could be hit, and however, the functionality was kind of bilateral, though we cannot swear by functional MRI for memories. So the parents were of the opinion that, well, they have a huge out-of-pocket expenditure. The surgery is out of pocket. The electrodes are out of pocket. The investigations are done by the government. So till the MEG, till the PET, till the SPECT, everything is free for them. But when it comes to the surgery and electrodes, it's expensive. And definitely, if they have to go in for a staged surgery where they wait for one part we remove and then we go for the second, which means dueling the surgical expenditures. So all this counseling took place, and they wanted everything out in a single stage. And definitely we were sure that it's not just a hippocampal pathology. There is ictal onsets coming around the fusiform gyrus. So we had no doubt in our minds, and looking back at all the MEG, the SPECT, leaving that would have been hazardous. Vis-a-vis a young child who's going to grow out of, will need a rehab. So with this counseling and explicit consent, we did go ahead, and the child is now back to school. He is studying and he's doing well in class, is not the brightest of the kids, but then he's managing to scrape through and pass the examinations. And so
I congratulate that the maximum achievement with the minimum number of the SEG.
Yeah.
So that
Yes. So okay. So maybe we are running out of time.
Yes, we are running, and I would like to request Professor Ikeda to give us a few more minutes in this webinar, because it was an interesting case. So
Yeah.
we have data
Okay.
lectures. So with your permission, we'll like to extend it by a few more minutes.
yeah, I think we can go on to the didactics and get back to the case
Yeah.
later.
Okay.
sure.
So first, Dr. Nandini Mulati, could you please start your didactic lecture? Yeah.
Well, thank you very much for that interesting case. And in fact, you've made my my talk easy. So I'm just going to run through the first couple of slides. We all know that mesial temporal sclerosis is a very nice surgically curable epilepsy, and temporal lobectomy is one of the most commonly performed operations. But seizure and seizure freedom is 70%, more or less, but it is only 70%. It is not 100%. And how do we identify the 70% who's going to do well? And how do we identify the 30% that's not going to do well? Really, and I'm sorry to belabor a point that sounds, very low tech, but actually very critical, is getting the best history you can get. If you can get a nice aura of a rising sensation in the stomach, feeling sick in one's stomach, fear, anxiety, a history of behavioral arrest, a feeling of déjà vu, or feeling of familiarity, or rarely abnormal smells and tastes, and so on, that will really be important and critical, and it's worth spending the time to get that history. And of course, when the patient then loses contact, as the seizure progresses, there is often behavioral arrest with oral automatisms and hand automatisms, lip smacking, and dystonia of the contralateral hand. So before we go to what are the red flags, when do you have a green flag to proceed to surgery? This is the 70%. So you have a nice epigastric aura, history of déjà vu, nausea, loss of contact, the oromotor and limb automatisms, a contralateral dystonia, and dysphasia if it's a dominant hemisphere mesial temporal sclerosis, or ictal speech in a non-dominant hemisphere involvement. So there are three basic investigations you have to do before really you proceed to surgery. One is of the MRI, the second is the scalp video telemetry, and the third is neuropsychology. And of course, history is the clinical neurological examination. In addition to an MRI giving you a positive evidence of mesial temporal sclerosis, you want the scalp video EEG telemetry to show the semiology as we've described, and also ictal EEG evolution, showing the electrical seizure onset over the appropriate anterior temporal electrodes. Because of where the holes in the skull base are, the mesial temporal sclerosis, the electrical field of the EEG is maximum over the anterior temporal electrode, which is F8 on the right or F7 on the left, or T1 and T2, T3, T4. Usually, neuropsychology shows reduced memory relevant to the appropriate temporal lobe. So if you have all of these matching, you say the findings are concordant and you can proceed to surgery. Now, in the case we discussed, the MRI showed us an MTS, but the history didn't give us a good history. In fact, didn't tell us anything to suggest temporoinsular involvement at all, which is what the symptoms mostly are. But it was discordant, giving us temporoccipital localization of the semiology. The EEG interictally was maximum over T5, which is the posterior temporal electrode. And neuropsychology showed reduced memory on the correct side, but the semiology, the history, and the EEG, ictal EEG were discordant. Now, this is just a typical anterior temporal. So this in my slides, red is on the right, and you can see a typical ictal evolution over the anterior. This is anterior temporal, F8 on the right, F8 going up to T to A2, and which is really all anterior temporal, evolving to a 6 to 7 hertz hippocampal rhythm. So this is a typical rhythm that you will get, which is really not what we saw in the patient. It was not anterior, it was posterior, and it was a faster rhythm, again, suggestive of a focal cortical dysplasia in the patient we saw. And ictal semiology remains invaluable in pre-surgical evaluation of patients with temporal lobe epilepsy. And to get a 1A outcome, this is a recent paper from Epilepsy and Behavior from the Milan group. When there is classical semiology, they're more likely to go into 1A. But when the semiology deviates, then you tend to have, or there's a greater likelihood of having angle 3 or 4. And although in their statistical analysis, the two features that came out were inferior limb stepping like movement or post-ictal dysarthria, actually the number of symptoms you can get are myriad. Almost every patient is unique, and there is a big group. It's a heterogeneous group when the symptoms are discordant. So just to, and all that group has been put into what we tend to call the Temporal Plus. Now, and the reason for this is that the reasons for persistent seizures after temporal lobectomy is not well understood. There is, of course, always the question, has the hippocampus been completely resected? And in a minority of patients, that is the case, that a bit of the tail is left behind. So in only about 20% of patients does further resection improve seizure outcome. And the second question is, well, is there independent seizure onset on the other side? But depth electrode studies, again, in failed temporal lobe epilepsy patients don't show this. And it's only a minority of patients that account for independent seizure onset on the remaining side. The other point, of course, was this a pseudotemporal case? That is, there is actually a lesion outside the hippocampus and or outside the temporal lobe, and to some extent, that is what this patient was, because if we hadn't had the PET, the MR hadn't shown us anything, and the orbitofrontal region, as well as the posterior temporal region, as well as the parietal lobe and the insula, all spread to cause what look like temporal lobe seizures. In fact, additional pathology to think of is also hypothalamic hamartoma. So pseudotemporal seizures is the definition of when there's an extratemporal, the actual seizure onset is extratemporal, but then it spreads to the temporal lobe and the seizure semiology manifests then. And of course, in such patients, if you do a temporal lobectomy, the outcome is poor because the source remains left behind. So this is the concept of temporal plus epilepsy. And this is a term used for when the epileptogenic network is noted to be wider than the temporal lobe alone. Initially, the definition was based on SEEG, and by and large, because these are patients who are discordant, and the second lesion is usually not MR visible, hence the question of, is this still temporal epilepsy? Because if the second lesion is MR visible, then we don't have the discussion. The discussion usually comes when the second abnormality is silent. I think PET MRI co-registrations have been really transformative in this regard and pointing out pathologies which the MRI, on the MRI alone, would be considered quite subtle, or we wouldn't have the confidence to proceed to surgery alone, just on the basis of the subtle abnormality on the MRI, as exactly happened on this case. It was when the PET MRI co-registration gave us much more of a confidence that there was, in keeping with all the semiology and the ictal EEG, that there was a lingual fusiform, a collateral sulcus pathology in this case. So the temporal plus epilepsy is a heterogeneous group. They could be frontotemporal, i.e. spreading from typically from the orbitofrontal region. They could be temporoperisylvian, they could be temporoinsular, or they could be temporoparieto-occipital. And the definitions of temporal plus, by and large, has been made on the basis of SEEG. And on stereo EEG, the electroclinical features are primarily temporal lobe, which was not in this case, in the case we just discussed, the seizures, although there were temporal lobe features in the automatisms and loss of contact and so on. The MRI in temporal plus epilepsy could be unremarkable or show mesial temporal sclerosis. And the stereo EEG showing either simultaneous or independent seizure types starting in the temporal and extratemporal location. And in our case, there was an independent seizure onset starting posteriorly. And of course, why do we need to know about temporal plus epilepsy? It's because the surgical resection strategy is much wider. So there is a resection of the mesial temporal structures, so resection of temporal lobe and additional extratemporal cortex, dependent on where this is defined. Now, what's very important is at this point, we should remember that temporal lobe epilepsy, mesial temporal sclerosis itself can spread extratemporally, particularly to the insula or the frontal lobe, and produce semiology relevant to, for example, the frontal lobe. So you can have mesial temporal sclerosis. About 5% of patients with mesial temporal sclerosis spread frontally, and you can get hypermotor features in the latter part of the seizure. In such patients, mesial temporal resection is enough because the source is the mesial temporal sclerosis. So when should we start thinking about temporal plus epilepsy? And these are, as I said, this is really a heterogeneous group. Almost many patients, there is too many descriptions to account. It's not a homogeneous group, and almost every patient is unique. So I'm just giving some clinical clues which might suggest where the additional pathology or additional epileptogenic zone or is located, or where the epileptogenic network is involved. So if there are symptoms of choking or difficulty to breathe or pain or warm or cold sensations, these all suggest insular involvement. If there are prominent sensory, eye movement, vestibular symptoms, they could suggest parietal involvement. If the symptoms of an auditory aura, vestibular symptoms, unusual experiential symptoms suggest additional temporal neocortical involvement, or a visual aura, blurring of vision, alexia, or as in our case, visual hallucinations could suggest occipital or temporoccipital involvement. And for example, if there's forced thinking, hypermotor features could suggest frontal involvement. And I just very quickly will share a case, which was a 32-year-old lady with MRI showing left hippocampal atrophy, but she had 5 seizure types. The first seizure type was as if she would be overcome with fear. It would be sudden, and the word she said, it was as if she was injected with fear. She would be very scared, start screaming, and it was all in preserved consciousness. Or she had a second seizure type when she would say, I'm suddenly unable to produce words. So she knew what she wanted to say. So there was intermittent dysphasia in the presence of preserved consciousness. And then, so these 2 attacks, there was no impairment of consciousness. In the third type of attack, she would feel, she just called them alien attacks, and she couldn't describe this better than as if, although she knew who she was, her brain was taken over by an alien. And she couldn't describe anything more than that. She would say, I feel like I'm an alien, I'm not me anymore. And so we found it difficult to kind of tease that out, but there's certainly some impairment of our definition of self, even though she knew who she was. She said she knew who she was, and she knew how she felt was not right. And the fourth one was indeed a complex partial seizure with loss of contact. And the fifth one was where she would get déjà vu with nausea and a rising abdominal sensation. So there was one of a 5 seizure semiologies which suggested mesial temporal sclerosis, but the others were, all unusual. And the PET MR co-registration suggested a basal hypometabolism in addition to the mesial hypometabolism. So in fact, we implanted with 8 SEEG electrodes, implanting the lateral and mesial electrodes B, C, and E would go into the amygdala and hippocampus, but also implanting the temporal basal hypometabolism, perisylvian and orbitofrontal region. And we could reproduce the habitual seizures on stimulating both the basal hypometabolic region as well as the amygdala and the anterior cingulate. But on SEEG, the seizure onset began with the at the lesional electrode, that is the temporal basal, because the electrode in the temporal basal where there was hypometabolism, that's where we hypothesized the lesion was, and we call that the lesional electrode. But it spread very quickly, just within 1 second, as you can see. This is 1 second here, these black lines, and you can see just within 1 second, the pre-existing rhythms have stopped and a new high-frequency discharge is appearing, spreading to the amygdala and hippocampus very quickly. So she went on to have a resection of the temporal base and the hippocampus, and she hasn't become completely seizure-free, but her seizures have, probably because the basal resection was not complete, and it was MR negative, so it was difficult to know exactly how much to resect. But just to show you how the symptoms patients can present with can be so different. And just again, some types of symptoms, which if you were to look at temporal lobe resected patients, when you go back and look at them, and you look at the patients who do well, and the patients in whom you hypothesize temporal plus epilepsy, or they have had SEEG because of temporal plus of these symptoms, semiology. Patients with temporal lobe epilepsy have the typical classical aura, while with temporal plus epilepsy, they're more likely to have a taste, an abnormal, a vestibular aura or an auditory aura, which would suggest temporal neocortical or parietal involvement, a more frequent and early contralateral head or eye movement, piloerection, which is thought to be insular involvement, ipsilateral tonic motor signs, and the EEG being abnormal, being bilateral, not classical anterotemporal, but bilateral or precentral ictal abnormality or interictal abnormality, and the ictal EEG being more prominent frontally, temporally, or precentrally, or occipitally, as may be the case in that particular individual. So, having said that, this is one other case I wanted to share with you. Again, I shall be quick. This is a 23-year-old left-handed individual whose epilepsy began at the age of 12, no previous history of febrile convulsions. And his seizure semiology was this. He's a good historian, He said his seizures always begin with dizziness. And then he would get a trembling or a twitching of the lower lips. And only after that would he lose contact. Then he would stare and be unresponsive. So this is by no means classical history, no epigastric aura, no déjà vu. He has this dizziness and then this trembling of the lower lip, which is really temporal of the lower lips, which is a opercular symptom. Dizziness, it's always difficult to know where to localize dizziness. Is this vestibular? Is it just the way the patient describes it? People call lightheadedness, dizziness. So then of course he loses contact, he stares, he's unresponsive. So there were these red flags. The MRI did indeed show mesial temporal sclerosis, but the semiology was suspicious. So he went on to have SEEG, sampling the temporal lobe and the opercular regions. And I'm just going to show you his trembling of the lip, which is something I have never seen in another patient. So what I'd like you to focus on is, this is his face, obviously covered, but there is an electrode over his lip. And can you see how that electrode is trembling? It's not clonic jerking, but so I should probably stop the video here because you can start seeing his face and we don't want to see that. It's not relevant to see his face. But what is really, I have never seen this symptomatology of this kind of, it's a trembling. It's not clonic jerking, but that trembling. And you can see that trembling on that kind of fast waving of the it's actually the plaster and it was small amplitude, that repeated contraction. And I've never seen that in a patient like with or without hippocampal sclerosis, I have to say. And what did it actually turn out to be? The onset, this is a guy with hippocampal sclerosis. The seizure onset was indeed from the anterior hippocampus, from the amygdala and anterior hippocampal electrode. But 40 seconds later, it spread to the opercular electrodes. And that is when he had that chin trembling, and he would only lose contact later when both the hippocampal, we implanted the right and the left hippocampus, and he would only lose contact later on when both hippocampi were involved. So in fact, even though this patient had a semiology which we would call temporal plus, on SEG, it was proven that the seizure started much earlier in the hippocampus, 40 seconds earlier, before any clinical manifestation. And this was clinically silent. His clinical symptoms only began with that chin trembling 40 seconds after the seizure onset. And then, of course, it spread to both hippocampi, and then he lost consciousness. So he went on to have a right-sided hippocampal resection of the right. He had a right temporal lobectomy and is seizure-free. So every patient tells us something new, and every patient is interesting. And things are never black and white in epileptology. This is what I've learned. So it can give us guidance, but always keep an open eye and an open mind as far as patients are concerned. So to conclude, temporal lobe epilepsy can involve an epileptogenic network that extends far beyond the mesial temporal structures into temporal neocortex, or indeed extratemporally, as we've seen. The careful analysis of the history of the aura, the seizure semiology on video telemetry and ictal EEG is therefore critical. And if there are disparities from the classical presentation of concordance, and I would urge everyone to remember, it's not just the MRI, you need the MRI, the video EEG telemetry and neuropsychology as baseline. And if they're all concordant, you're safe to go ahead to the temporal resection. But if there is discordance, then further evaluation with either phase 2 investigations of PET MRI, of phase 1B investigations with PET MRI and SPECT, etc., should be considered, or SEEG. And this is irrespective of whether there is hippocampal sclerosis or not. So I'll stop there I hope I've stuck to time. Thank you very much.
Okay, thank you very much, Professor Mulati. Wonderful, educational lecture, and that beautiful video of, opercular symptom. Yeah,
it was so amazing. That is his first symptom, and this is a hippocampal sclerosis patient.
Yeah, okay. And, we have the questions in the chat box, but we'll take those questions at the last part of this session. And before that, is there any question or comments specifically to Dr. Mulati's the lecture from faculty or audiences? Is it okay? Okay, Dr. Ikeda.
I think we can proceed to the next talk, and then we can take all the questions. Yeah.
Okay, then the next the talk is by the Professor Debu, and the title is Surgical of Temporal Plus Epilepsy. So please start the lecture.
Okay, thank you very much for your invitation. Do you hear me properly?
Yes.
Yes.
Slide is
Good,
okay.
excellent.
Yeah.
So thank you once again for your invitation, and thanks for this very interesting case you presented. We may discuss further because there's still some questions. As Nandini told, temporal plus epilepsies from a surgical standpoint, I'm a surgeon, those epilepsies where seizures arise from a part of the temporal lobe and neighboring cortical area, which is different, and she told that already, from temporal lobe seizures with a secondary propagation. And these temporal plus epilepsies are, first, relatively rare. Second, they constitute a heterogeneous group of epileptic patients with different semiological presentations from involvement of different structures, various epileptogenic lesions, and we come again back to this particular question, and it implies different surgical strategies than that in our institution have changed over time. And this temporal plus can also be defined as the temporal lobe epilepsies which fail to be cured by an adequate temporal lobe surgical procedure. So they involve first temporal lobe, more or less extended, anterior propagation to basically orbitofrontal cortex and inferior frontal gyrus, which is a challenge in the dominant side. May involve the operculum, precentral operculum, or postcentral, right of operculum. The temporal parietal junction, which is then basically the supramarginate gyrus, and that's called the pericilium. Most of them are called the pericilium epilepsies, and finally the insula, as Nandini told. All these extra-discharge propagation are done through subcortical pathways, and they're very numerous. And they drive not only ictal discharge spread, but also functions, and basically motor and language functions. And so we have to consider them and to take them, to try to spare them during surgery if we can. Our previous experience, because we, in Saint-Anne institution, SEG was invented and introduced during the late 50s years, so it's a long time of practice. Our pre-op investigation has moved over the time and include clinical data, neuropsych. Don't forget psychiatric evaluation. I'm going to talk one word on that, especially on temporal plus epilepsy patients. Structural and functional MR, scalp EEG, video EEG, and PET scan. That's a 18 FDG PET scan. Most of patients underwent video EEG and SEG, leading to surgery in most cases. And about 10% during this non-invasive pre-op investigation could move directly to surgery. So those are some pictures of recent SEG practice in Saint-Anne Hospital. So now I'm going to show you some very old pictures of temporal plus epileptic patient operating at Saint-Anne many years ago. Our surgical strategies were mostly extended corticectomy, which is a resection of cortex of several areas. This was based on pre-op investigations, basically MR, SEG data, and electroclinical features. The resection was customized, and the surgeon was guided by this very old-looking schematic representation of anatomy and resection planning and SEG electrodes position, because we see when we open the dura, we can see the sticking of electrodes, placement with dura and to cortex, and so make the correspondence during surgery between the electrode position and data and what we see under the microscope. Here's a case of a 27-year-old woman who had HHE syndrome, around hemiconvulsion, hemiplegia, epilepsy syndrome, with a large atrophic area of the right hemisphere, During ECG, stimulating the amygdala induced a seizure and that demonstrated a large epileptogenic zone, including the temporal lobe, starting at electrode A, amygdala, B, hippocampus, and rapidly involving the perisylvian areas that led to this particular larger resection. This is the temporal lobe, the anterior valley, the supramarginal gyrus, angular gyrus, and suprasylvian areas. Don't look at this very ugly stuff that's hemostatic material, sogecel and powder of collagen. I don't use them again. I don't use them any longer. And this girl had a pretty uneventful post-op course, and she was class 1B at 5 years, just all right, but she had a severe psychiatric disturbance after surgery, and she committed suicide 5 years after surgery. And from that, and I don't know if you share this experience, those larger resections that we made in the past, we don't do them any longer, created in many patients psychiatric disturbances. We had suicide, I think we had a second suicide after a similar resection. So we moved to smaller resections that tended to complement with multiple pile transections, and we operated a couple of cases, not many, 4 or 5. This is a case of a 15-year-old girl with temporal lobe epilepsy and hippocampal sclerosis, but also, you can see here on the Frère sequence abnormality in the temporal pole. I quite always remove the temporal pole in hippocampal sclerosis. Temporal epilepsy, several seizures a day, large perisylvian hypometabolism, you can see on this early PET scan, and the ECG with a large implantation of temporal and perisylvian electrode demonstrated epileptogenic zones starting from temporal structure, visual and lateral temporal structure, quickly involving the perisylvian regions, and we did this operation on the right side, the Sylvian Valley, temporal resection, and additional transpire transection, like laser fiber or whatever instruments. It's just the principle of creating incisions in a cortex. And she was, after 3 years post-op, in a class 2B. That means that we didn't reach completely the goal. She has still had some nocturnal seizures. This is post-op MR. And well, we didn't do that for a very long time because our referral patients changed. I'm going to talk about that. So this early experience, we look at the results of our series from 92 to 2009, and multilobar insular and perisylvian epilepsies over 1 year follow-up, mixing lesional and non-lesional cases. A little more than 50% of them were class 1, but only 45% class 1A, and with a fair large number of incomplete results or completely failed results. And so it was due to several factors. We changed a little bit of strategy. First of all, we had less patients with true cryptogenic epilepsy, because first, progress in your imaging and surgical options, and the second, obviously, accumulative experience, and also with less favorable results in non-lesional epilepsy. And I remind here the study of Zenteno, who made an analysis of many articles and demonstrated clearly that the prognosis in terms of seizure outcome was much better when patient had a lesion than no lesion, either on imaging and the pathological study of surgical infected specimen, and with the change in temporal lobe or extratemporal lobe epilepsy. So we moved from the concept of localization-related epilepsy to brain lesion-related epilepsy. And the case that you presented earlier illustrates perfectly this particular concept. And my message today would be to what you obviously did in the case you presented, to offer all the pre-op invasive or non-invasive investigation to try to make in the light a brain lesion that could be resected with the excellent seizure outcome afterwards. So we certainly in our patients have much less this patient with large scars from perinatal injury, post-infectious or post-traumatic scars, and increase the identification of malformation, cortical development. You know, that's our favorite topic. But also, we have to consider, and I'm being told that before, that temporal lobe epilepsy and caused by hippocampal sclerosis is not a homogeneous group of patients. And I'm going to start with that. My colleague Francine Chassot, who's my neurologist, and our group published several papers on this particular topic, highlighting the importance of PETs, the 18 FDG PET scan, co-registered with MRI, and also studied statistically to differentiate several groups of patients with temporal lobe epilepsy and unilateral hippocampal sclerosis. The mesial group, the prognostic is best because the network is limited to mesial structures, the pole, and the second spread to insula. The involvement insula is present in this group, but limited. The second group with a larger epileptogenic zone, the anteromesial lateral group with more hypermetabolic area in the temporal lobe, but also the insular cortex. The widespread mesiolateral group, which is a step beyond, with much larger epileptogenic zone and much profound hypermetabolic area. And this map is the same patients treated with SPM 99, and as you see in the mesial group, hypermetabolic significant as compared to normal subjects, much larger in the two more extended epileptogenic zone, and in those two last group, I just exclude bilateral group, which is a particular group of patients who can operate when seizure start clearly from one side. Our temporal plus cases are probably collected in those two categories. And she did a second work, which is interesting. She just split it into the 1A, which is completely seizure-free without any aura since surgery, and non-1A, with relative success, favorable and failures, which correspond to class 3 and 4 of Engel classification. And definitely there was a statistical difference in area of hypermetabolism between those groups. And in those patients, we obviously had a different surgical strategy with removing just mesial structures in temporal lobe in the pure mesial group, and more extended resections and the two other wider epileptogenic group zone groups. And obviously the results were even though doing this different strategy, were excellent in the mesial group, with 80% of class 1A, 43 in the second group, dropping down quickly. No patient in the class 1A in the widespread unilateral group, and by temporal, just 1/3 of those. So our current management of temporal plus epilepsy, as soon as we have focal epilepsy and more than temporal lobe, seems to be involved in the epileptogenic zone. Either the one visible lesion on MR scans, repeated if needed. The pre-surgical workup that also includes, always include a PET scan, leads to either lesionectomy or a little more extended resection. Or there's no visible lesion, and in those cases, PET scan is of utmost importance. And in those cases, we do also an SEG, and we try to find focal cortical dysplasia, which renders surgical operation successful, and lesion resection and more or less cortisectomy, depending on the location of dysplasia. If it's located in a primary high functional area, we just limit the resection to this plastic tissue. If not, we can just extend to the gyrus and circle borders of this page. And if no, we do a cortisectomy, but in those patients, the results are certainly are definitely poorer than in those patients. This is a illustrative case, 38 years old and seizure onset at 6, an atypical temporal stimuli with early bilateral tonic postural manifestations, but nocturnal seizures were very suggestive of a dysplasia, but previous MR were considered as normal. In fact, when we repeated high-definition MR scans, we can see in the T1, but more elegantly in the flight sequences, this tiny area at the temporal parietal junction here, EEG showed the right middle temporal spikes. Functional language functional demonstrated clearly the left dominance activation, and this dysplasia was located here. We can see on the picture the transmental sign, which is very suggestive, quite characteristic of focal dysplasia. And so PET scan showed clearly the hypometabolic area corresponded to the dysplastic tissue, and a statistically treated hypometabolic showed that the tiny spots corresponded exactly to the dysplastic tissue. Audition functional imaging showed that the auditory structures were just at the anterior border of the dysplasia, and we made this very limited resection of dysplastic tissue. It was a recent case, so I don't have any long follow-up. For the moment, seizure-free, but we'll see in the future. Second case, and I just have 3 cases, and then I conclude. Oh, sorry. Second case, 50 years old, much older for an epileptic patient, seizure onset at 26 years, with a temporal semiology, but traumatic falls, and an EEG right temporal plus central abnormalities. MR and the MR showed an extended perisylvian polymicrogyria. So we did a PET scan, which showed that only one part of the polymicrogyric tissue was hypometabolic, and it was confirmed by the SCG. We have implanted 14 electrodes, which is a large number of electrodes in our institution, and I would see that interictal abnormality started in the temporal pole, amygdala, anterior hippocampus, posterior hippocampus, and involving the polymicrogyric cortex. And once the seizure onset involved the same structures, starting from the very anterior part of the temporal lobe, and involving quickly either the medial structures and the lateral structures, polymicrogyric, and it's 4 electrodes. And so we designed this resection, and we found surgery a very harder tissue and harder in the temporal inner part of temporal pole, uncus, amygdala, and anterior hippocampus, rather than polymicrogyric tissue and lateral neocortex and the anterior part of the temporal lobe. It was a recent case. I don't have any long follow-up to tell you about the results. And the last case is also an interesting case of a young girl, 28 years old, ambidextrous, a musician, seizure onset at 9, atypical temporal physiology with a tonic and postural manifestation on the opposite side, and post-ictal language disturbance. And so functional language functional MR showed that she had a right dominance for language, corresponding at the same side where we found cortical dysplasia. But the initial MR scans were considered normal. In fact, repeat MR showed this blurring between cortex and subcortical white matter, and this area corresponding to the posterior part of the superior temporal gyrus and the junction with the supramarginal gyrus. And the hypometabolic area corresponded to this area with a severe temporal pole hypometabolic area, but the most important was in superior temporal gyrus and the junction with the parietal lobe. We did a resection under awake conditions with my colleague of low-grade glioma who had long experience in awake surgery. When we stimulated this posterior T1 gyrus, we got a speech arrest. But we have put cortical electrodes, and we saw that the post-stimulation discharge included also the temporal neocortex and suprasylvian regions, so that we resected with trust the dysplasia, because we know that there's no function inside the spastic cortex according to our experience. And so we have resected all the T1 extending to the bottom part of the supramarginal gyrus. And we had very mild dysphagia post-op, and she quickly recovered. But, and here's the resection extending posteriorly. She's not completely seizure-free. She had some nocturnal seizures, so she's in class 2B, and probably insufficient resection because all the specimens we gave to pathologists were abnormal, and included abnormal giant neurons and balloon cells. It's type 2B focal cortical dysplasia. So if I may conclude, surgery for temporal plus is certainly for a surgeon a difficult challenge, and a less favorable seizure outcome could be expected, but excellent outcome after surgery may be obtained after a focal lesion resection. Pre-op, pre-surgical investigation must be oriented to the search for a discrete brain lesion, basically focal cortical dysplasia. Type 2 has excellent prognosis. The other types are more widespread and more difficult to approach. The increasing role of structural and metabolic imaging still plays for SEG, but as soon as those structural and metabolic imaging will improve, probably the need for depth implantation and invasive monitor would drop down. We must remember that small SCD may cause a widespread EEG and SCG abnormalities. A very small bottom of sulcus dysplasia may cause a real mess in one hemisphere, and so that could account wrongly to a too widespread epileptogenic zone, inaccessible to surgical resection successful, which is not the case. But which is when facing a real non-lesional epilepsy, we expect unfavorable outcome, and probably we should reject those patients from surgical workup and operations. Well, thank you for your attention. I hope I was clear on the time, and it's interesting to consider that the presented case more or less illustrated my talk. Thank you.
Thank you, Professor Dubout. So your lecture about the kind of shift from the determination of the resection according to the EEG, but you have been becoming more and more lesion oriented, using high resolution MRI and the PET.
Yes, and it's important if you don't see anything on a standard MR to repeat it, because you know that according to clinical presentation and EEG, you have to find something. You have to find small, tiny area of dysplasia. And the case that has been presented before, it's exactly the same topic, and illustrate perfectly that. And in searching, increasing the investigation, finally we come to the point that there is something else than a pure hippocampal or visceral temporal lobe, the atrophic sclerosis. And that's very important. And probably with the growing experience, we could decrease the cost and the number of pre-op investigations, and most of them, obviously, the invasive seizure monitoring, to propose the same surgical procedure, which will be successful in most of our patients.
Okay, thank you. So
you're welcome.
Thank you. Yeah. So now, shall we move to the Q&A? Okay,
yes, we have some questions, Dr. Kawai. Maybe you can put up the questions now.
Yeah, okay.
We put up 5 important questions, so you can ask them.
Yeah, okay. And could we have done the surgery with only VEEG, MRI, and SEG? That means for this particular case, or generally speaking?
I think they meant for the first case.
First case.
I think they were concerned that their center may not have so many advanced investigations. So could we manage temporal plus only with video EEG, MRI, and an SEG?
So
given that,
yeah, please.
So sorry, no, given that this is, you're going to go into eloquent cortex, the MRI abnormality was not very clear. It would be, you know, I don't know what I mean, obviously the surgeons have to give you, but I think we would be reluctant to, Professor, you know, there are 4 surgeons on the call, so.
Okay.
This is always a challenge for epilepsy surgery. Yeah. And I think that's the greatest limitation, that the straightforward cases you can still do. But if you have to do complex cases, you would require so many expensive investigations. So I think it's a global challenge. I do not know how we would overcome that.
Can I answer? Can I try to?
Yes,
please.
Yeah.
So the thing is that, you know, one would be tempted if you don't have the PET and the SPECT to go ahead with at least removal of the left hippocampus. But then there is this visual aura. So, and it's the dominant hemisphere, as Dr. Nandini said. Now, doing something in the dominant hemisphere, which is irreversible, is a bit of a problem. But then if the country does not have investigations, the poor man's PET is the arterial spin labeling. And you can do the arterial spin labeling, and sometimes it can pick up something. In our case, it didn't show anything, but a poor man's PET will be the arterial spin labeling, which just takes about 3 minutes extra on the MRI system. Short of that, I don't know if your question is that you would go ahead with SEG implantation after the video EEG and the MRI, then obviously the number of electrodes which you have to use will be higher, because you don't know where exactly in that area it is. So you probably have to end up implanting 7 or 8 electrodes or more number of electrodes. So maybe that would give you an answer. So, but definitely, you know, the message is always to maximize the non-invasive investigations, do an ASL, etc. Yeah.
Okay, and question 2, from Egypt, how many electrodes are normally required for SEG? And can we reuse the electrodes? It depends on the country's, you know, regulatory rule. But how about in France and England?
I think because of obviously, you know, CJD and so on, they're all, I think generally electrodes are single use. Now, coming back to Manjari's point about, you know, and I think the cost of SEG electrodes is a real issue, because, you know, on the one hand, you allow the patient to have refractory seizures and die, or can you? So I know that, you know, electrodes which don't cost so much are being, you know, there is an attempt to make locally the electrodes. I understand from Trivandrum, Sharad, and Manjari, you may have heard this. So I think single use at the moment, single use, and how many electrodes? Well, it all depends. Every case is unique. And I mean, to some extent, Sharath and Manjari have opened our eyes by doing SEG with 2 electrodes, essentially. You didn't need the 3rd electrode in the other hippocampus. So, yeah, but I think to have done that case where you were going to cause a visual defect, almost certainly you knew you would cause a visual field defect. To do that without SEG, I think would be very difficult. But I think these are all qualitative answers rather than quantitative. There is no formula.
So how about Professor Debout? I think the French guideline for SAG indicated that you know, adequate number is between 7 and 14 or something. Is that right?
Yes, Well, we obviously you have only single-use electrode, but probably what could be just imaging is that some company that could deliver low-cost electrode could be a solution. Considering the number of electrodes, probably we're among other centers in France who use the SEG methodology. We're the one where we use the smaller number of electrodes. It's driven by experience, And as soon as you have a strong hypothesis, you're just going to use SEG for confirming that. While so many others still consider that the SEG is some sort of fishing expedition. You don't know exactly, so you're going to put an electrode and another one, and so you ended up with a 20 electrode within the brain bilaterally. And when we look at that, we know that the point won't be caught. And I congratulate Marjorie for having the job with 3 electrodes. And we could just discuss that the contralateral electrode could be not completely helpful. So she could have done the job with just 2 electrodes. And congratulations. In fact, the point is, if we come back to this case, and for me, the strong question, could it be possible to do the same surgical procedure without SEG? So using only the TAP, all the pre-op stuff made with the MEC scan, with the excellent TAP MR images. I mean, you focused on the fact that the collateral sulcus was hypermetabolic, and so was dysplastic. So what could it be? Well, it should be discussed. I mean, is the SEG necessary to achieve this goal? You had just 1 electrode in what we were convinced that there was a focal cortical dysplasia. So just with 1 electrode, you didn't, limit your surgical procedure because you had just 1 confirmation. Yes, it's dysplastic. You didn't show what the SEG showed. You had this pseudo-rhythmic discharge that we see in the intrictal phase. The focal cortical dysplasia could be one of the question. If yes, you don't need more in fact. And probably, our experience is that we implant less and less cases, even in deep-seated cortical dysplasia, because we know that now if you resect completely the dysplastic tissue defined by MR and the PET scan, that's enough to get a good seizure-free outcome. Not in all cases, but in most of them. And so probably you could progressively get rid of SEG and doing more non-invasive investigation to propose your patient a successful surgery.
And sorry to add just one additional point I want to make is actually Professor Davu from your team, and Sucharit, you asked this question once before. You have operated on MR negative, PET positive cases, but I think that's because your team is highly experienced. Very few centers do that, but you have operated on MR negative, PET positive, and with a good outcome. So maybe that's just an opportunity to just share that.
Yes. So so just to add what Dr. Nandini has said, may I, Dr. Devi, you want to speak first, Dr. Devi?
Just please.
So in our experience, our SEGs are highly hypothesis driven. It's perhaps that we are missing out some cases where we could have implanted many more electrodes and perhaps given them a good outcome. But we have found in our experience that 10 to 12 electrodes are where we get a strong hypothesis. If we implant more than 12 electrodes, we generally lose out the hypothesis. And generally, these people do not have good outcomes. So you may feel, so more number of electrodes exactly doesn't translate into better outcomes. Now, we have also...
In fact, worse. In fact, worse, because you don't know what you're doing.
Absolutely. And then we have found 3 categories of MRI negative. One is where you have some subtle lesions and you kind of put electrodes and then try to prove that this lesion is actually causing epilepsy. The other is the case what we presented where the MRI is normal, but we do more advanced investigations and retrospectively come back and then say that, yes, there is a lesion here. And again, it's hypothesis driven. But a truly MRI negative, and this is what I would like to ask Dr. Divu and Dr. Nandini, a truly MRI negative, where the MRI doesn't show anything, the PET is not concordant, the MEG is not concordant. What is your experience in dealing with this kind of cases?
So, but Ron will answer this. I think true MRI negative and PET positive. Of course, if everything is negative, you cannot operate. That would be unethical. But Bertrand has, and that's what I wanted him. I think it would be very useful to learn about that, where MRI is negative and PET is positive. So Bertrand, if you could share your experience, please.
Yeah, thank you. It's fairly difficult because things are changing. We just consider MR negative according with our MR units, but with the increasing high field MR scan will show abnormalities when the previous lower field MR showed before. But as a matter of fact, when everything is concordant, I mean, semiology, EEG, MR negative, PET positive, there is dysplasia, and we are sure that we're going to find it. And there's no 0% and 100% in medicine, but in the vast majority of cases we found dysplasia. The last one is obviously the pathology. So we have type 2 focal dysplasia. I don't care about type 1 and 3. We don't know what kind of stuff is it. It's just really different. We're talking about type 2 focal dysplasia, which fortunately are the most frequent. And I should say that when everything is negative, when we're convinced that patient might have a focal epilepsy, we would still implant. I don't have in my memory in any cases of that. We implant on a CEG, but we need to have very strong focal abnormalities on a CEG to offer certain. Otherwise, we reject from surgery and we put VNS or new antiepileptic drug. So, but in the case you presented, Manjari, I would just the hypermetabolic area did not completely differentiate from other areas hypermetabolic, and I was not 100% convinced. We were convinced because of the whole presentation, clinical, EEG, MEG. Maybe in those cases, statistical analysis or redo the PET is difficult because it's just a radionuclide injection, but change the thresholds to get a better image, more clear, if I may say. If it's the case, you're sure that you have a dysplasia. If you have dysplasia, you operate, and in your case, you extend to mixed structures, we would have done the same. This is a question of quality of imaging, not only in acquisition, in post-acquisition treatment. And if you have a good treatment, post-op treatment of MR, PET, it's you have the MEG calculation. We don't have it, and we have no experience on MEG. We have additional non-invasive methods that could make you offer less and less CEG, costful CEG to the population. And meanwhile, with a large number of patients, you accumulate your experience, and you end up with a MR negative, PET positive is very small dysplasia at the bottom of the sulcus. Even with a high resolution imaging, you operate and you get a successful outcome. That's more about experience.
Okay, thank you.
Dr. Ikeda? Dr. Ikeda would like to answer that about the SEG and Dr. Ikeda?
Yes, the one quick question and comments. In the first case, shown by the Tripathi, I was very impressed that the MEG was actually the pointing out at the answer, although it is in the measure. So the MEG is actually the whole brain. The whole MEG may be much more the important things in case of this kind of temporal plus epilepsy. because that it is purely non-invasive. So the reason why you succeeded by that the minimum number of the electrodes is just by that the multiple investigation, especially I feel that the MEG on your particular cases. So of course that the SAG is very strong to find out that the network, but the MEG as a whole head is also second strongest tool. So in the near future, I hope that the MEG may play more role. That's what I expected at this moment. Yeah.
Okay, thank you. So how about the question 4 about the same about the particular case, and if the patient had had the uniform visual hallucination like flashes of light, not some figure on letters and. Do you have any?
That would indicate, the primary visual cortex involvement, and that would make it even more difficult to, kind of resect completely, because that will lead to terrible deficits. Probably we do a tractography and look at the tractography. We'd probably have to counsel them for a visual field deficit, which is extensive. Like this patient just had a little thing in the up in the sky, but we'd have to counsel them for complete hemianopia or something like that. So I think that's going to be a very difficult thing to do. The occipital lobe lesions which occupy the visual cortex, primary visual cortex. Yeah.
And
Why you can take question 5. I think that's very relevant.
Oh yeah, the question 5. But how about before that, the question number between 3 and 4?
Yes.
Trembling. This is about symptom. Can trembling hands be a symptom or complication of major temporal sclerosis from India? So
I think the answer is no. Just briefly, by and large, no. I think it's a question of what you call trembling. So I'm just showing my hands here. So automatism is just, you pick, or it's some kind of automatic behavior patient doesn't know. But there is this entity called wrench. So patients can do contralateral hand kind of rhythmic clonic movements. So that's how they're rhythmic.
Non-clonic
movements, but they look, kind of, I guess, maybe some people could think they look like trembling, but if you think trembling is like a tremor, no. But if it's unilateral focal, it could be a wrench sign.
Yeah, I actually have this. Yeah, I actually have the similar feeling, but that reminds me of the faciobrachial dystonic seizure. Although we call the faciobrachial dystonic seizure, it contains some sort of myoclonic, very trembling movement of the hands. So the trembling hands movement may share that the similar generated mechanism, the responsible for that subcortical basal ganglia are common to that the faciobrachial dystonic seizure and some the very fine trembling hands in the temple of the origin of the focal seizure. Yeah, that's what I feel.
Have you seen it in temporal lobe seizures though? I take your point about it being in faciobrachial dystonia, which is really an autoimmune encephalitic manifestation, isn't it? Have you seen it in mesial temporal sclerosis seizures?
That's actually happened involving that the both amygdala or the hippocampus, but it doesn't last so long. So it doesn't make finally the atrophy, but the swelling is the major finding. And the ones that treated, the swelling has now resolved, but it didn't usually go to the sclerosis. So and then it's now migrating to the other parts in case of autoimmune encephalitis, autoimmune epilepsy. That's what I personally feel.
Interesting, thank you.
Okay, thank you. So the question 5 from Malaysia. There are some papers mentioning that VEEG is not required for medial temporal sclerosis. Only in a good quality EEG and MRI is good enough. Please advise. Everybody.
100% okay with that. If you have, this real, when everything is completely concordant, semiology, scalp EEG, MR, and if possible, PET scan. You don't need any. You don't need a 3 spontaneous seizure recording or video EEG. You don't need them. You just operate, and you're going to have a more than 90% rate of seizure-free outcome.
So how will you decide semiology? You mean semiology by history, Bertrand?
Yeah. Well, the semiology you perfectly described, Nandini, with a few temporal. You have a slide with the opposite TLE plus and TLE. The semiology of TLE, when you get that, sclerosis on MR, hypermetabolism on PET scan, they just go to surgery. You don't care about it.
Oh, this is so. You see, this is
questionable. It's debatable, but I'd like to give my viewpoint.
Yes,
about 15% of patients with refractory lesional epilepsies have pseudo seizures, and we pick them up only when we do a video EEG. So you are going to operate a patient without a video EEG. You missed out on those pseudo seizures. And after surgery, there is some funny thing happening again. So that's number one reason. Number two reason, a lot more goes on when we admit the patient to the epilepsy monitoring unit. It's not just the video EEG. We are optimizing the anti-seizure drugs. So patients come with 5 anti-seizure drugs, and just 2 are enough. So we taper off 3, we do the video EEG, send them on a substantial dose of 2 or maximum 3 drugs. So you're optimizing the drugs in the window of opportunity during the video EEG. That's the second thing. The third thing is you need to see the semiology, just like this kid. You could clearly have mistaken him as a mesial temporal lobe. Even after seeing the video EEG, so much of nausea and epigastric sensations, you would have thought of mesial temporal lobe. So unless you have seen the complete evolution, which will be missed on a home video, the patient's relatives can give you home videos, which may often miss out the initial part of the seizure. Of course, they do try to capture the seizures with all efforts. So you would have missed out the initial part, which is the most crucial part. And the testing which is done during the video EEG in terms of looking at the responsiveness and looking at the naming and language, all this gives us an idea of the ictal onsets, the ictal propagation. And in fact, the video EEG, if you follow the semiology right from the onset till the termination, can actually tell you, if you put in 6 or 7 SEEG electrodes in the patient, what the propagation will be, if you tease out the semiology in the video EEG. So I think it is rather brave that people have published papers where mesial temporal sclerosis has been operated just based on MRI and an interictal EEG. I think it may be a scenario where the number of cases of MTS were huge. But personally, I feel if we cannot put back that brain which we have removed, we ought to be sure of whether we should be removing it in the first place, particularly when patients have temporal plus or have an insular involvement. It's going to be difficult if you end up with failures and you don't have a baseline video EEG. So you did the surgery without the video EEG and the patient has failed surgery. Then you repeat it. Now you knocked off a part of the temporal lobe. You have effect on the EEG because the temporal lobe volume is gone from there, and you're seeing peculiar EEG patterns post-operatively. We know that there is this, effect, breach effect, and all those things. So really, I think it is prudent that we follow protocol, and we really do not think of this concept of going ahead without a video EEG. If we are very sure it's MTS, once we admit the patient and we find that the patient has the first seizure, and that seizure, we show it to the relatives, and the relatives say this is the typical seizure and there is no other seizure type. This is the only seizure the patient has. Then maybe we can do with 1 seizure and still go ahead with surgery rather than documenting 3 seizures. But at least that 1 seizure should be documented, because we have been surprised when we think it's mesial temporal. Like in this patient, there was a left temporal sclerosis, and we were surprised when we did the video EEG. We were surprised when we further investigated. So I think we should take every case individually, and we must emphasize that a video EEG needs to be done in a straightforward MTS where there is hippocampal sclerosis and there is a single seizure, which is the only seizure type, maybe you can just do with one video EEG event, but it still needs to be done.
So I have to, I rarely disagree with Professor Davu, but this is one of those occasions.
Yes.
Only because exactly the point Manjari makes, I think it is really important to do the video EEG. And the other thing is, you see now, the EEG machines are computerized. So they all have video EEG anyway. You know, it's not that hard to do a video EEG. You don't need a dedicated telemetry bed. You can just put a video EEG machine on a patient in a ward, record the seizures for all the reasons, you know. Even, as you say, even in good centers, epilepsy surgery outcome is only 70%, even in mesial temporal resection. So the causes of failures are quite high. So the answer is, I think this panel at least feels that video EEG, scalp video EEG is essential baseline.
Yeah, Nandini, I quite agree with you, but you know, in some countries and in some rural areas, so even, you know, digital EEG is quite limited. And in those cases, doing video EEG is not easy, actually.
But so this then becomes an ethical question, doesn't it? Because, you know, do you allow the patient to die, or do you just operate on the basis of MRI? So, you know, he could have SUDEP and die. Okay, because of it's a difficult question to balance.
Yeah, sure. Okay.
If I may answer, because just answer, because I'm very sorry, I was a little bit provocative. In fact, this is not that we do video EEG on a daily basis in almost all our patients, except a tiny group of patients in whom everything is so clear that we don't know exactly what would be added. And I completely agree with you, Manjari. But if you come back to a case, obviously the unusual and atypical presentation is obviously outside the group in which we wouldn't perform video EEG. We always start, and you show my slide, we start with a pre-op investigation from video EEG, and especially, I presented our papers about the heterogeneous group of mesial-temporal lobe epilepsy and hippocampal sclerosis. Obviously, those different groups were based also on different video EEG patterns. So it's limited to a small number of patients, very typical, and if obviously in the hands of very experienced teams that who know that for this particular patient or patients, video EEG will add much more, and it's not a good thing to expect video EEG, which is scheduled for month after, because you have too many patients, and to wait for potentially highly successful surgery on a pre-op investigation, which is not completely necessary. That's it. But if you prefer that we forget the fact that video EEG is useless, okay, but it's not useless, but it may be avoided in some particular cases. That's what we do in some limited patients. And
maybe we can have the last comment from Dr. Ikeda before we close this session.
There's one more question for Professor Davu, I think. There's one more question which is actually quite relevant.
I think we are running very late.
Oh, I see.
Essentially, both. In order to select the very typical cases, for some resources limited country may skip the long-term video EEG monitoring. In Kyoto University, we have the criteria to skip the long-term video EEG monitoring, as the Manjari mentioned, that the clear hippocampal sclerosis documented of the typical semiology by video, or the reliable witness like family members. One more thing is that half-day EEG, inter-EEG to documents that indicate the spike only on the one side more than 90%. Then we could skip that the video imaging monitoring, but this is now much more limited because the typical MTLE is now decreasing number, but we used to do in 1990s or early in the 2000. Yeah, we have this kind of criteria, but this is now minority.
Thank you very much, Dr. Ikeda, for your kind of conclusion. Is that okay? So, how about concluding now, Sarat?
Yes, we can. So thank you very much. So we have had a very serious and a very exhaustive discussion. And
Sarah, can I ask one very quick question to Dr. Dabu?
Yes.
Yes, the lecture is very much impressive to the new concept of your temporal plus the epilepsy, the emphasizing on the presence of the lesion. So today is that the Manjari, the presentation is the dual pathology. So my question is that is there any overlap between the dual pathology cases and then temporal plus epilepsy cases, although it may be minority?
Thank you for your question. It's difficult to answer because of the. I don't know if I don't know if dual pathology is so dual. I mean, this young boy had a fairly recent 3 years of frequent seizures. Does it? The question is the dysplasia, which was the initial, which was seizure onset zone, or seizure onset lesion, let's say, spreading to the anterior part of the temporal lobe. Did this atrophy was present when the seizure started? I mean, really two different seizure onset spots, which I don't believe, and I think that Marjorie don't believe also, or is it a progressive atrophy of temporal lobe, which is hit by the high number of seizures coming from dysplasia, because we know that the dysplastic tissue is so epileptogenic that it's certainly it has the leadership of the seizure onset. And so, is it a true dual? It may be, but probably if you had if this team wouldn't have rejected the mesotemporal structures, probably a second type of surgery would have emerged after the first resection, successful resection, but with a secondary epilepsy. So it's probably in this case, I'm not sure of that, dual or consequent pathology due to the high discharge rate of the epileptogenic lesion and the posterior temporal lobe. That's what I think.
Thank you very much.
You're welcome.
So can we conclude? Professor Kawai?
Yes, yes, please.
So thank you so much. And thanks to both the faculty for their excellent lectures. And it has been a very, very deep and a serious discussion. And thanks especially to the experts from Japan. It's way beyond midnight, I think. But they have so patiently sat here and participated in all the discussions. And before I conclude, on behalf of AOILE, I would request Professor Ikeda to say a few words, and then we conclude.
Yeah, thank you very much. This is the 6th time as spending the last 6 months. So that would be one of the most important the discussion time among the ILA Asia and Oceania. We share that the common interest and problems that's raised. That's the more forward step together with the ILA Asia Oceania, and I really appreciate that the Dr. Dabu and then the Dr. Nandinina. So we learned very much. Thank you very much.
So
thank you. It was a pleasure to be here. Thank you from both of us.
It was a real pleasure to share with you, and very friendly and scientifically interesting for me. Thank you so much for all of you. Thanks, and I hope we'll see you again in the next webinar.
So thank you very much, Have a wonderful and a safe weekend till we meet next week, next month once again. Thank you so much.